Okay, hey guys. So we're going to do chapter 28, face and neck injuries. We're just going to kind of cruise through this one. I'll try to point out what I feel is pretty important. Um, but yeah, we'll get started if I can get my computer work. And there's a fly buzzing me, so if I'm swatting, I promise I'm not losing my mind. So introduction here. The face and neck, they're vulnerable to all kinds of injuries. Soft tissues, fractures are very common. Some injuries can be life-threatening. We're going to talk about penetrating injuries of the neck, which can cause that severe bleeding. The open injuries may result in air embolisms. We'll discuss that later. So, just jumping right into it here, the cranium, it consists of the brain. The most posterior portions is called the occiput. Sorry, we're gonna screw up right from the beginning, I guess. Lateral portions of each side, your temporals and your temporals regions. The forehead's called the frontal region. The anterior to the ear in the temporal region. You can feel a pulse of the superficial temporal artery. I would not use this as a pulse point. It is very hard to find. We've got six major bones, your nasal bone, two diagmos. I never can say that. Yeah, sagamus. Two maxillas and your mandible. So your mandible is your lower jaw. Maximals is going to be up here, your top. Um, Max grows a mustache. That's how we remember that. And then the one I never can pronounce, and I'll quit trying to butcher it. It's the orbit of the eye. Okay, it's your cheekbone, and it's the bottom portion of the orbit of your eye. There we go. Uh, the orbit of the eye, it's composed of your lower edge of the frontal bone in the skull, diagma, maxilla, nasal bone, protects the eye from injury. It covers approximately, I think, we'll look at it later. I think it protects 80% of the eye is what it does. Um, the face, the only proximal third of the nose is formed by bone. There's going to be a picture coming up here in a minute, but I think we know that the outermost part of our nose is cartilage. There we go. The exposed portion of the ear is composed of the entirety of cartilage covered by skin. The pinna tragus and the superficial temporal artery. Um, I'm not going to lie to you, just for testing purposes and quiz purposes, yes, we need to be able to identify these things. I've talked to you a little bit. Once we're out there in the field, lower jaw, um, orbit of the eye, um, left side of the head. That's how we word things out there in the real field. So don't get too carried away with memorizing every medical term. We just need to know kind of where they're at. Let's see the face. So about 1 inch posterior to the external opening of the ear is the mastoid process. The mandible forms the jaw and the chin, which we've talked about. I am going to backtrack for just a second because I think, okay, yeah, that right there, quit. See if I can do this. There we go. So this right here, I never can pronounce all that. It's the hinge of the jaw. I just want to point that out because there might be a question on that later. Okay. The neck, it contains many important structures we know, supported by the cervical spine. The upper part of the esophagus and the trachea lie in the midline of the neck, so it's in the middle. It's protected all around. The carotid arteries are found on either side. At this point in class, we've been checking pulses at the carotid arteries. You should be able to identify them pretty simply. The larynx, Adam's apple, is located in the center of the neck. Other portions of the larynx is the cricoid cartilage. We're going to talk a little bit about it. Once again, I don't want to get hung up on this. The cricoid membrane lies between the thyroid cartilage and the cricoid cartilage, uh, thyroid cartilage and cricoid cartilage. I'm sorry. I found this picture online. I thought maybe it would help. Ben's I do nothing but confuse people. So thyroid is above, cricoid is here. That membrane, we hear of like paramedic stuff doing a cric on people. They're going right here into this membrane is where they're focused. And that's why I don't want to get hung up on this because this we need to kind of know where it's at, but it's not super important for us. Now, if we take injury of some type, let's say a car wreck and we hit our throat on the steering wheel, okay? Now we need to kind of worry about it. We need to watch for swelling. We need to watch for that internal bleeding. We definitely need to hold C-spine. That's the kind of stuff you need to think of because there is a lot of structures here that can be damaged. We got our trachea down here. These rings, they're called your, yeah, not trachea. Um, They are the rings built of cartilage. I can't think of the name, save my life right now. Cricoid rings. There we go. They actually keep the trachea open. It's what keeps it from collapsing when we breathe or anything like that. So they're just a solid piece of cartilage that holds the trachea open. Let's see the neck. So the trachea below the larynx connects the oropharyngeal and the larynx with the main passages of the lung. If you guys remember our respiratory chapters, we've discussed all this. Um, I absolutely hate this next word because I can't say it. The sternocleidomastoid mastoid muscle. If you'll just remember the SCM, which once again, don't get caught up on this. It's this muscle right here. It ties back here and then down here, and it keeps everything in line and kind of helps protect. Um, I'm trying to read my notes here. Originates from the mastoid process of the cranium and inserts into the medial borders of each collarbone and the sternum at the base of the neck, allows movement of the head. That's what the SCM does. The eye, globe shape, approximately 1 inch in diameter, located within a bony socket of the skull called the orbit, um, composed of adjacent bones of the face and skull, protects over 80% of the eyeball. So we're talking about that glow or the orbit, right? Um, and I think there's pictures coming up later, maybe, maybe not, where you can actually see that 80% tucks back inside our orbit, so it is protected. Just kind of a picture showing you different areas of the eyeball. This is in your book. I know, I guarantee you, quiz and test questions are going to ask about the iris, the cornea, the pupil, the lens, maybe the optic nerve, retina. No, I know that sounded like a lot. Those are the main things it's going to talk about or ask about. So the eye, clear jelly-like fluid near the back of the eye is called your vitreous humor. In the front of the lens is a fluid called the aqueous humor, which can leak out in penetrating injuries. This sounds horrible. If anybody out there's a deer hunter, when you were a kid, you touched the eyeball. I promise you did. Um, that jelly, nasty stuff, that's what that is. Maybe I'm the only one that does that. I don't know. The conjunctive is a membrane that covers the eye. The lacrimal gland produces fluid to keep the eye moist. Uh, the tear, the tears drain on the inner side of the eye through two lacrimal ducts into the nasal cavity. It was in my notes. Um, the sclera is the white fibrous tissue that helps maintain the global shape. When the front of the eye, um, or that area is replaced by a clear, transparent membrane called the cornea. Oh, sorry. Okay. I confused myself there. Sorry. It allows light to enter the eye. The iris is a circular muscle behind the cornea. I do not like the human eye. I don't like studying the eye at all. The pupil is an opening in the center of the iris, allows light to move to the back of the eye. Um, there is a condition in which people have different sized pupils. It's not because of head trauma. It's not because of drug use or anything like that. Anosclerosia, if you can pronounce it, brownie points to you. The lens lies behind the iris, focuses image on the retina at the back of the globe. I'm ready to get off the eye already. The retina contains nerve endings, responds to light by transmitting nerve impulses through the optic nerve to the brain. The retina is nourished by a layer of blood vessels called the cricoid. That's not right. The choroid. Okay. Retinal detachment causes blindness. Obviously, we knew that. Let's see. Injuries to the face and neck. Okay. This will be a little bit better. Can often lead to partial or complete obstruction of the upper airway. Several factors may contribute. So we got to look at things like blood clots from heavy facial bleeding. We are very vascular in the head and face area. Um, direct injury to the nose and mouth, larynx and trachea, dislodgement of teeth, dentures into the throat. Anytime that there's trauma to the head, face, or neck area, we've got to do our ABCs. We've got to focus on our respiratory. Swelling that accompanies direct and indirect injury. Swelling that accompanies direct and indirect injuries is considered can be considered a life threat. Airway may be affected when the patient's head is turned to one side. Possible injury to the brain and cervical spine. I think we know that. Um, face and neck ex are extremely vascular. We talked about that. Swelling may be more severe. Skin and tissue in these areas have a rich blood supply. A blunt injury can cause a hematoma. I put this last one on here. Brain bleeds can show signs and symptoms immediately, or in some cases, take weeks to start showing signs and symptoms depending on the severity of the bleed. I want to throw that in there because I have personally had a call where the guy fell. He had a huge hematoma. Um, Answered all questions appropriately, refused all care. Even his son refused care. We made him sign the refusal. It was like 4 hours later, we get called back to an unresponsive person, get him to the hospital. He does have a brain bleed. It took about 3 hours for it to actually start showing signs. The son said he become altered after 3 hours, become pretty much unresponsive after four, got him to the hospital. They shipped him out. He died 2 days later, because of a brain bleed. So it really affected me. I pay really close attention, especially elderly people. If you get a fall with a minor hematoma or even a severe hematoma, let's go ahead and educate our patients. Hey, yeah, I know you're doing great right now. If they absolutely refuse, then we need to educate family. Someone stay with them. They need to talk to them. Watch for signs that they're deteriorating so it doesn't get to that unresponsive stage. Uh, Dental injuries. Uh, your mandible fractures are common. Most injuries are the result of a vehicle collision and assault. Signs of a mandible fracture. So, misalignment of the teeth, numbness of the chin, the inability to open the mouth. Um, this happens a lot in your vehicle collisions or even with ejection, but they're still alive, their jaw will just fuse shut. It's hard to open that airway. Um, Maxillary fractures are usually found after blunt force high energy impact. Signs of maxillary fractures include massive face swelling, instability of the facial bones, misalignment of teeth, fractured and avulged teeth are common following facial trauma. So we're going to look for those broken off teeth. So I threw this picture up there. It just kind of shows you a before and after. We've got some major facial trauma going on. Now, if we put the skin over that and it wasn't just an x-ray, you're going to see swelling, probably some bleeding. You're going to see bruising, severe bruising. There's all kinds of stuff, but we can see that the teeth are off, that jaw looks shifted. And then after, of course, surgery, he's all kind of patched and fixed up. But it just gives you an idea of what's taking place under the skin. So, scene size up, observe for hazards and threats, look for hazards, even violent or environmental problems. Eye protection and mask are standard. Determine number of patients. Mechanism of injury or illness. Let's use our index of suspicion here. We want to assess scene. Mechanism of injury for face and neck injury. So we're looking at like motor vehicle crashes, sports, falls, penetrating traumas, blunt traumas, anything where we have an outside force putting force on the body. Focus on identifying and managing life-threatening concerns. Um, Threats to your ABCs. If there's anything in the ABCs not adding up, we got to stop and fix that right then. When there is a life threat, external hemorrhage, it should be addressed immediately. So remember, if we have hemorrhaging, it goes CAB instead of ABC. We take care of circulation, then airway, then breathing. Form a general impression. Look for important indicators about a seriousness of the patient's condition. Injuries may be very obvious or hidden. I cannot stress enough about distracting injuries. Oh my God, that laceration on the arm's amazing looking. That's really cool. But we didn't notice, the hematoma behind the ear. So we have battle signs. So we have head trauma. Those are the kinds of things we got to pay attention. That's why we do a full assessment on every patient. Control blood loss with direct pressure. Consider the need for manual spine stabilization. Check for responsiveness using your AVPU scale. Airway and breathing. Ensure clear and patent airway. If the patient's unresponsive or has significant altered level of consciousness, consider a properly sized OPA. If they have a gag reflex, we cannot use that. We're talking about face and neck injury, so face injuries, we can't use an MPA either because that is a contraindication. So we need to figure out what we're doing there. Quickly assess the adequacy of the breathing. Splinting or otherwise restricting chest wall movement is contraindicated as well. So we want to use our DCAP BTLS, um, and we start at the head and we touch everything. We look for all injuries. We cannot restrict the chest at all. Even though this is a head or face injury, they still have to be able to get that full range of motion to breathe. We need to be ready with suction. We need to be ready to take that airway if we have to. We just got to be very vigilant on these people. Circulation, so quickly assess the pulse rate and quality, determine skin condition, color, and temperature, check capillary refill time. Significant bleeding is an immediate life threat. We know that by now. Um, with these patients, we definitely have to keep an eye on them at all times. We don't want to keep our back turned for, very long at all. I know in the back of the truck we're going to be busy. We're trying to grab stuff and prep things, and I've had patients who were talking to me 1 second, and I literally turned around to grab something out of the cabinet, turned back around, and they are in full shock. It happens in the blink of an eye. So, anytime that we are dealing with bleeding of anywhere, we need to pay close attention to that person. Transport decisions. Consider quickly transporting patient with airway or breathing problems or with significant bleeding. Consider ALS backup. A patient with internal bleeding must be transported quickly for treatment by a physician. Transport decisions, signs of shock. Hypoperfusion. That is a rapid transport shock is a life threat. The patient who has a significant mechanism of injury, um, but whose condition appears stable, should be transported promptly. Once again, common sense, index of suspicion. If the passenger or another occupant in the vehicle died in the vehicle, then it is on automatic. Your driver might say they're fine, but it was severe enough to kill someone else. That's a high index of suspicion. They need transported properly or promptly. Um, so just use your common sense. Study the car, study the patient. It might not be a car, it could be a fall. Study the height. What type of surface did they land on? That's the kind of stuff we got to look for. Any significant blow to the face or throat should increase your suspicion of spinal injury or brain injury. Once again, common sense. Um, Investigate the chief complaint. So obtain a medical history. Be alert for injuries, specific signs and symptoms. Be aware for um, pertinent negatives. Gather a sample history from the patient or from friends and family. Whoever's there, question them. Ask questions. Um, I've said it in previous chapters, but in this job, we ask questions. We talk to anybody and everybody. We can't be shy and do this job. Physical examination. Um, multi-system. If multi-systems have been affected, start an assessment of the entire body, looking at DCAP BTLS. We're talking about face and neck injuries, so it's gonna be a trauma. It falls under trauma. We do a trauma assessment, and that consists of head to toe, touching everything. We look at it. We listen to lungs, heart, and gastrointestinal area. In the In a responsive patient with an isolated injury with limited mechanism injury, consider focusing on the isolated injury, the patient's chief complaint, and the body region affected. So I don't want to be a hypocrite here, but you're going to be trained or you're being trained to trauma assessment. We touch and look at everything. Medical assessment, we focus on the body part, but we kind of pay attention to others' body systems. So out there in the real world, yes, if I have a little kid who fell off his bike and broke his arm, do I need to strip him down and check his pelvis and legs and everything? Absolutely not. We take our mechanism of injury, we take our index of suspicion, our common sense, if you will, and we go, okay, I can clearly identify this patient's fine, they just broke their arm, versus a car wreck where I can't see inside that human body and I don't know what all's going on. That's when I'm going to go like full tilt trauma assessment. So there is a fine line there. Keep that in mind. Um, for classroom, for testing, when we have a trauma assessment, we do a trauma assessment. Out there in the real life, we use some common sense. I hope that makes sense. I don't mean to confuse anybody, but that's kind of how it works. Um, Physical examination again, ensure and control bleeding and maintain and note injury locations. I keep a notepad on me. I do my full assessment. I treat life threats. I'll treat my secondaries last, but I'll also write down, and it might just be like L arm break, um, right foot abrasion, and I just kind of take notes because when I call in my report later, I know exactly what I'm going to say. And two, in a big situation, sometimes we get sidetracked on those bad ones and we forget to even look at our secondaries. So if I have everything written down, I can always go back to it and kind of a checklist, if you will. Um, Inspect the open wound for any foreign material and stabilize impaled objects. Use both your eyes and your hands. Assess all underlying systems. This fly is driving me nuts. When evaluating the eyes, start with the outer aspect and work towards the pupil. We've all been there, whether you've watched it on Cops where they check their eyes or in a doctor's office, they never shine it at your nose and go out. It's always out to in and then back out. Um, Examine the eyes for any obvious foreign matter visually, acuity is a vital sign of the eye. Um, look for discolorization, bleeding, redness, uh, isometric symmetry. Make sure they're equal. Pretty much when we look at those eyes, we want them the same size and they need to react to light equally and at the reasonable same amount of time. If I check the left eye and it reacts to light normally, and I move over to the next eye and it reacts, but it's a lot slower, then I don't have a problem. Um, vital signs, assess vital signs to obtain a baseline. I've said it before, baseline vitals are a cornerstone in what we do. Um, you must be concerned with visible bleeding and unseen bleeding inside the body cavity, obviously. Our blood pressure, our heart rate, our respiratory rate, it's all going to indicate we have bleeding if it's major enough. With facial and throat injuries, baseline information is very important. Use appropriate monitoring devices. So, what is a monitoring device that we can be using? We're looking at face and neck injuries. So our blood pressure, once again, our pulse, our respiratory rate, our body temperature, are we in shock or not? What about a pulse ox? If we put a pulse ox on them, is it going to indicate that we have good respiratory um, drive? Are we perfusing like we should? Is our body oxygenating? And the reason I keep going back to respiratory is because what drives our respiratory, what controls our head, right? So if we have face or head trauma, we can have spinal injury, neck injury, which can actually affect everything below the side of the injury. So yeah, we might just not be getting that signal to other parts of the body. Um, so just because we get a small face or neck injury doesn't mean it's not life-threatening. Repeat the primary assessment, reassess vital signs and chief complaint, reassess patient's condition every 5 minutes when they're severe. If they are a major call, it's 5 minutes. If they are stable and good, it's every 15. Interventions provide complete spinal mobilization if necessary. If they fail, if they say their head hurts, if they say their neck hurts, if they were in a car wreck and it was mechanism of injury indicates that it was at pretty good speed. We need to hold C-spine. We need to apply that cervical collar as soon as we're done with our hands-on inspection of the neck area. Interventions, maintain an open airway. Be prepared to suction and consider an OPA. Once again, we can't use MPA with facial damage. OPA, if they're awake and they have a gag reflex, we sure can't use that. Um, Remember, we're talking about injuries to the neck and spine, so we might even be doing a jaw thrust maneuver to open that airway. Whenever you suspect significant bleeding, provide high flow oxygen and control significant visible bleeding. We got to stop the bleeding before we can oxygenate, though. I don't like the order that's in. No point in giving oxygen if it's just going to be shooting out of an open wound. Interventions again. If the patient has signs of hypoperfusion, treat aggressively for shock and provide rapid transport. How do we treat for shock? By this point, you should know. We're going to lay them flat, cover them with a blanket to maintain body heat, and apply high flow oxygen with a non-rebreather. Communication and documentation include a description of the mechanism of injury and position in which you found the patient. This is super important too. My example I like to use is you have a 68-year-old male who you got a call because he fell from a ladder. So what's something we need to do when we roll up to that scene is I'm looking at how tall the house is. Um, I'm looking at the surface that he landed on. Is he laying on his back? Is he laying on his stomach? Is he on his side? Is he moaning, groaning, yelling, crying whenever I start to approach him? These are the things we need to communicate and document, whether we're talking to the hospital or we're doing our patient care report later on after the call. Those are important findings. Treat soft tissue injuries. So we're on emergency medical care, sorry. To the face and neck, the same as soft tissue injuries anywhere else on the body. We're going to do our ABCs, treat life threats first, follow standard precautions. An absence of life-threatening bleeding, first open and clear the airway. Let's make sure that airway is open. Avoid moving the neck of patients with suspected cervical spine injuries. This is where that jaw thrust comes into play instead of head tilt chin lift. If at all possible, we need to do our work right there where they're at and then worry about moving them once we have them secured on a backboard, head blocks, all of that. Um, Talk to your patients while you're doing this. Um, People absolutely hate C-collars. Every one of you who come to my class will wear a C-collar at some point. You will experience what you're doing to that patient. You will be strapped onto that backboard so you understand. So talk to your patients, let them know what you're doing. Be honest with them. Let them know this is uncomfortable, but this is why I have to do it. Control bleeding by applying direct pressure, manual pressure with dry sterile dressings. Use roller gauze wrapped around the head to hold pressure dressing in place. Do not apply excessive pressure if an underlying skull fracture is suspected. If they're bleeding from the head, what I kind of tell my class is moderate pressure. We want it to bleed a little bit. We don't want it gushing. We don't want it pouring out, but it bleeding a little bit is fine because if we just stop the pressure and the bleed is still taking place inside, where's that pressure going? It could be going against the brain. So instead, we moderate pressure, let it bleed a little bit. That way, we're not pressuring up inside our cranium. Cover exposed brain, eye, or other structures with moist sterile dressings. Apply ice locally to injuries that do not break the skin. For soft tissue injuries around the mouth, check for bleeding inside the mouth. Um, so we can let gravity do its thing, have them lean forward and the blood can come out. If they're awake, alert, following commands, we can have them bite down on like a 4x4 or something. We can have them hold gauze against the cut, depending on where it's at. We never ever want to impede our airway. So it's kind of a per patient type of deal. Um, don't pour blood stop into the mouth, the powder. That's a bad idea. Um, it just depends on the injury and the patient's condition, how we handle that. Sometimes we're going to actually have to suction that out ourselves. Um, Physicians can sometimes graft a piece of avulsed skin back into position. So an avulsion, if we need to take a step back, is when we get that big flap of skin, um, or it has completely come off, a chunk has come off. Most of the time, it's going to be a flap. We need to make sure that's clean, but we just put the flap right back where it was, and we wrap it with sterile dressings. If it's completely off, we can place it in a plastic bag, keep it cool, but don't put it directly on ice. Label and deliver to the emergency department. So sometimes they can reattach that piece of skin that completely came off. And when I say skin, it can be muscle and fat tissue as well. It's not just a little scrape. It can be a large piece. Um, for evolved skin, um, is if the avulsion is still attached in a loose flap, place that flap in position as close as normal as possible. Like I said, hold in place with dry sterile dressings. We're gonna flop it back over, and we're gonna wrap it up. Injuries to the eye. Eye injuries are common, particularly in sports, can produce lifelong complications, including blindness after an injury. Pupil reaction or shape of the eye movement are disturbed. Um, Throwing stuff again. Abnormal pupil reactions sometimes are signs of brain injury rather than the eye injury. So to keep that in mind. Index of suspicion, mechanism of injury. We're going to repeat this 1,000 times. Uh, Treatment starts with a thorough exam. Always use standard precautions. Take care not to aggravate any problems. We don't ever want to make anything worse than what we found it. Look for abnormalities and conditions that may suggest the nature of injury. Sometimes these people can't tell you what's wrong, so it's our job to investigate that. Foreign objects, um, the orbit protects the eye from the penetration of large objects. Uh, Even a small object may produce severe irritation. Irrigation with a sterile saline solution will frequently flush away loose particles. Sometimes it won't. I think we're going to get into it here in a minute, how we flush or how we secure an eye object or an object in the eye. Always flush from the nose outward because we do not want to flush it in deeper. So it's always inside to out. Um, like here, it looks like they've got a nasal cannula that they've turned into an eye wash station, which is pretty cool. A foreign body will leave a small abrasion on the conjunctiva. Um, Gentle irrigation may not wash out the foreign bodies stuck to the cornea or lying under the upper eyelid. Um, let's see here. Foreign body may be impaled in the eye, bandage the object in place. Okay, so I'm not going to read all that. So if we get an object that is actually embedded and we can see it, it's an impelled object. We want to, one, secure that. We're not pulling it out. We want to secure it in place, whether we're using bandages or whatever we can. We also, at the same time, we work on the injured eye, but we cover the other eye. Because what happens is if I'm injured here and there's still movement, when I move my good eye, this one's still moving. So we actually want to secure both eyes, cover both eyes, secure that object however we can. It's just like any other impelled object. We bandage or we secure it and then we bandage around it so that hopefully we don't bump it. One of the methods that they use, and I don't know if it's going to talk about it or not, is even cutting the bottom out like a Dixie cup and putting that over it so that nothing can bump the impelled object. Burns to the eye, stop the burn and prevent further damage. We want to start flushing as soon as we can. Usually caused by acid or alkaline solution. Flush the eye with water and saline. Direct the greatest amount of irrigation solution or water into the eye as gently as possible. If they have contacts on, we need to try to get those contacts out as quickly as possible. Um, eye wash stations and companies, they have protocols they follow. If you're called to a house or something, you know, we keep normal saline, we keep flushes. We just need to start irrigating as quickly as we can to get the burning to stop. You may have to force the lids open, flush the inner to outer corners. If the burn was caused by an alkali or strong acid, irrigate continuously for at least 20 minutes. After irrigation, apply clean, dry dressing to cover the eye and transport. We do not want to sit on the scene for 20 minutes just pouring water. Let's do part of this in the truck if we can. Thermal burns, so during a fire, the eyes will close to protect from heat and the eyelids will burn. Transport promptly without further examination. Cover both eyes with sterile dressings, moistened with sterile saline. Apply eye shield over the dressing. Light burns, so infrared rays, eclipse light, laser beams, all can cause significant damage. Retinal injuries caused by exposure to light are generally not painful, but may result in permanent damage. Severe conjunctive, usually conjunctive, I can't say it, usually develops with redness, swelling, and excessive tears. This could go right into welding. I know this part of the country, a lot of people know a welder, weld themselves. It's terrible. I grew up around it. I don't know how many times I've burned my eyes, and it is absolutely terrible. Um, Lacerations to the eye require very careful repair to restore appearance and function. Bleeding may be heavy, um, but it usually can be controlled with gentle manual pressure. If there's a laceration to the globe itself, apply no pressure to that eye. We're not going to try to control a bleed if there's actual laceration to the globe itself. On rare occasions, the eyeball may be displaced from the socket. Do not attempt to reposition it. Cover the eye with stabilize and stabilize it with moist sterile dressings. Cover both eyes to prevent further injuries. Have the patient lie supine. If any of you are fans of Night Watch, there's an episode where a lady gets her eye popped out and it's just kind of dangling. Really cool. Blunt trauma to the eye. Hyphemia occurs all or part of the iris obscures, sorry. The orbit fracture is a fracture of the bone that forms the eye floor and supports the globe. Retinal detachment is often seen in sports. I'm ready to be off the eyes already. Eye injuries following a head injury. So signs and symptoms of a possible head injury. One pupil larger than the other, eyes not moving together, failure of the eye to follow your finger, bleeding under the conjunctive. I'm not even gonna try anymore. Um, Protrusion or bulging of one eye. All of these are like it's red flags. You've got to pay attention to every one of those. Blast injuries, signs and symptoms range from severe pain to loss of vision to foreign bodies within the globe. If there is a foreign body within the globe, do not remove it. If only one eye is injured, follow your local protocol. Call medical direct. If you have questions, you're uneasy, ask for help on these. If the patient has severe swelling, do not force the eyelid open to examine it. Contact lenses and artificial lenses, we talked about a little bit. Do not attempt to remove contact lenses unless there is a chemical burn. To remove a hard contact lens, use a small suction cup. To remove soft contact lenses, yeah, we reach in there, we pinch together, and we pull out. Um, Once again, I'm going to repeat this. Chemical burns, we've got to get the contact lens out as soon as possible. We do not want it melting to the eye itself. So there's your suction cup. Then pinching a soft contact lens out. Uh, what's B say? To remove a soft contact lens, install 1 or 2 drops of saline to or irrigating solution. This just helps lubricate it and easier to grab it. Nosebleeds. Remember this word, epitaxis. Um, that means nosebleed. It is a national registry question that I got wrong. One of the most common causes of um, digital trauma, anterior nosebleeds usually originate from an area of the septum and bleed slowly. Posterior nosebleeds are usually more severe and often cause blood to drain into the throat. Epitaxis. Learn that word. Blunt injuries to the nose may be associated with fractures and soft tissue injury of the face, head injuries, and or injuries to the cervical spine. Assess the nose structure for injury. Um, your septum, if well, you should know this, it's the centerpiece. Um, Sorry, I'm trying to read here what that says. Okay. I think we've already talked about all that. Let's see, patients with severe nasal injury may also have a cervical spine injury. Cerebral spinal fluid or CSF may escape down through the nose following a fracture at the base of the skull. Control bleeding by applying a sterile dressing. I'm surprised it didn't go deeper than that. So we want to lean a patient forward, have their head slightly down. They can pinch the nose. One other thing your book's not going to teach you is lay an ice pack on the back of the neck. This will constrict blood vessels and it will help slow that bleeding down. Um, if they are on any type of blood thinner, we definitely need to ask them about that on these patients because it can significantly make this a worse situation. I have transported people um, all the way to Oklahoma City, 3 hours away because of a nosebleed before. So these can be actually a life-threatening situation. The injuries to the ear, divided into three parts: your external ear, middle ear, inner ear. I'm sure there's stuff in here that I'm gonna butcher. Um, so we got our pinna, our outer ear, external auditory canal, and then we've got our tympanic membrane. You've got the hammer, the anvil, stirrup. I never could say that one, but the cochlea. It's the ear, pretty much. Um, Ears are often injured, but do not usually bleed very much. In cases of the ear avulsion, wrap that avulsion part in a moist sterile dressing and put it in a plastic bag. So if that ear's gone, we try to save it. Um, Tympanic membrane rupture. Patients will report severe ear pain, difficulty hearing, and ringing in the affected ear. May be caused by insertion of an object too far into the ear. Children place foreign bodies in the external auditory canal. Clear fluids coming from the ear may indicate a skull fracture. So now we we're looking for clear fluid, a yellow color fluid, or blood, ears and nose to indicate that spinal fracture or skull fracture. Facial fractures typically result from blunt impact. Assume a direct blow to the mouth or nose has caused a facial fracture. Other clues indicate bleeding in the mouth, inability to swallow or talk, absence or loose teeth, loose or movable bone fragments. Um, Once again, it might not be obvious on the outside, so this is why we need to open the airway and we always look into the mouth for the blood, the teeth, um, any of that. If we can get it out, finger sweep. If they can get it out, even better. If not, we're suctioning. Facial fractures alone are not acute emergencies unless there is serious bleeding. Plastic surgeons can repair the damage to the face and mouth of injuries, also treated within 7 to 10 days. Swelling can be extreme within the first 24 hours after the injury. What are we worried about here? We are worried about spinal injuries and airway affecting. Like it can affect our airway. That's what we really need to worry about with a facial injury. Um, Swelling, bleeding, aspiration of blood, um, dental dental injuries can be traumatic to the patient. Bleeding will occur whenever a tooth is violently displaced from its socket. Apply direct pressure to stop that bleed. Perform suction if needed. Cracked or loose teeth are possible airway obstructions. There we go. Um, if they are able to follow commands, they're awake and they're alert, yes, let them hold that pressure on the bleed. Hand them 4x4s, let them hold it in there. Um, Otherwise, we're probably going to be suctioning blood. Save and transport any teeth that we can find. Handle it by the crown rather than the root. Place the tooth in two storage solution, cold milk, or sterile saline. On a truck, we're going to have saline. That's our choices there. Notify the hospital of what's happening. Um, Reimplantation is recommended within 20 minutes to an hour after the trauma. It depends on the trauma. They might be in the hospital for a week. So it just depends on the situation. You may encounter an object impaled in the patient's cheek. Um, One, we want to control bleeding. We don't ever want to remove an impaled object. I don't care where it is. There's only two times that we do that. One, if it's impaled in the cheek or mouth and it affects our airway, or two, which is a whole nother chapter, if we're impaled in the chest and we have to do CPR, we can pull something out then. But point being, we leave everything in place, we secure it in place to where it can't move anymore. We control that bleed and then we transport with the object where it was found. The neck change structures valuable, vulnerable to injury by blunt trauma. So upper airway, our esophagus, cricoid arteries, and jugular vein. Thyroid cartilage, your Adam's apple, cricoid cartilage, upper parts of the trachea. So anything up here, if we take blunt trauma, we can have injury. Blunt injury, any crushing injury of the upper part of the neck is likely to involve the larynx and trachea. It can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, and leaking of air into soft tissue of the neck. Um, Subcutaneous emphysema is what that is called. Um, you'll get almost a Rice Krispie type sound or little bitty tiny air pockets under the skin. You'll know it when you feel it. Blunt injury, subcutaneous emphysema is characterized as crackling sensation produced by presence of air. Complete airway obstruction can develop rapidly. Consider ALS support early and consider spinal motion restriction. We definitely need to get ALS on these because we might have to drop like an ET tube on these people. Penetrating injuries can cause profuse bleeding from lacerations of the great vessels in the neck. Injuries to the carotid and jugular veins in the neck can cause the body to bleed out. If the vein has been punctured, an air embolism may result. We don't want to get air in there. The airway, the esophagus, and the spinal cord can be damaged by penetrating injuries. Direct pressure over the bleed site will control most neck bleeds. Follow steps in your book on drill 28 through 3 or dash 3. Assess for signs of shock, initiate spinal motion restriction and indicate as indicated, and apply high flow oxygen. So when we do direct pressure, let's say our jugular vein, we go above and below the site of the wound and we put pressure. We do not want to just squeeze and cut off circulation on both sides. So the other thing we can do, because we're worried about air getting in there, we can also do a chest seal, seal it, and put pressure through the chest seal. Um, Laryngeal injuries, so blunt trauma to the larynx can occur. Unrestrained driver strikes a steering wheel as an example. Um, Snowmobile riders or off-road bikes strikes clotheslines or fixed wires. We definitely gonna get some neck injury there. The larynx becomes crushed against the cervical spine, resulting soft tissue injury, fractures, and or separation of the fascicula. These strangulation injuries can also be found in either international or intentional or unintentional hangings. Um, Anytime there's suspected injury to the larynx, suspect possible cervical spine injury. Let's see. Penetrating or impaled objects in the larynx should not be removed unless it interferes with cardiopulmonary resuscitation. Um, Stabilize all impaled objects if they were not obscuring the airway. If they're able to breathe or we're able to breathe for them, we leave it where it's at. Significant injuries to the larynx pose an immediate risk to the airway compromise or risk of airway compromise. Signs and symptoms of larynx injuries include respiratory distress, hoarseness, pain, difficulty swallowing, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising on the neck, hematoma, and bleeding. Just all things that we need to look at. Signs and symptoms again of the larynx include, why is it repeating that? Hang on. I kind of went over all that already. Sorry. To manage these, provide oxygen and ventilation, apply cervical immobilization, but avoid rigid collars. So they make those soft collars. Whether your truck carries them or not, depends on where you're at. Most places around here are going to be the rigid collars. So this might be one of them cases where we just hold C-spine the entire time. If we're working in this area, we might just have to have someone hold C-spine the whole time. So I think we've made it through this chapter, and I'm so happy. Was not my strongest. Which of the following statements regarding the Adam's apple is false? You guys can pause and answer these. I'm going to go ahead and just kind of cruise through. So it is A. That is false. It is inferior to the cricoid cartilage. Moving on. The globe of the eye is also called this one should be pretty simple. It's also called the eyeball. Let's see, when a person is looking at an object up close, the pupil should, it's going to constrict. The answer is B. When caring for a chemical burn to the eye, the EMT should, we want to prevent contamination of the opposite eye. We want to, don't make it worse than it already is. A. Which of the following signs is least indicative of a head injury? We're going to go with B, pupillary constriction to a bright light. That's what should happen. Number six, the purpose of the, yeah, another word I can't say. Tube is to, the answer is C, equalize pressure in the middle ear when external pressure changes. When caring for a patient with facial trauma, the EMT should be most concerned with, I've preached it until I was blue in the face this whole chapter, airway compromise. The presence of subcutaneous emphysema following a trauma to the face and throat is most suggestive of, it's going to be C, a crushing tracheal injury, leaking of air into the tissue. A 21-year-old male has a large laceration to his neck. When you assess him, you note that bright red blood is spurting or shooting from the left side of his neck. You should immediately, well, we can't apply a pressure dressing to the neck, so that's not going to work. How about C? We use a gloved hand over the wound. One, going to help slow bleeding. Two, it's not going to allow air to get in there and get that air in blue. Which of the following mechanisms of injury would most likely cause a crushing injury to the larynx and or trachea? Definitely, it's going to be A, attempted suicide by hanging. So, guys, I know this was a rough one. Thanks for sticking it out. Um, Hopefully, the next one's smoother. I will see you on chapter 29.